Hello, and welcome to the Advanced ICP Waveform Analysis 6-Minute Synapse series. In this session, Advanced ICP Waveform Analysis, we will very briefly cover the basic concepts of the ICP waveform and then dive into the etiology behind how and why this is important. We will also look at Lumberg ICP waveform trends, why we see them in our patients, and what the cause is behind them. My name is Kenna Seal, and I'm a neuroscience nurse and clinical specialist for Natus. So now let's get into the analysis. What should your ICP waveform look like? Well, it should look somewhat like a descending waterfall with 3 waves, P1, P2, and P3. You can see in the strip that the P1 is the peak wave, and then P2 and P3 follow. P1, the first wave, should be the peak wave. It is the big push of blood flow into your brain. Most of this wave originates from the choroid plexus inside of the ventricles. Because the P1 wave is associated directly with blood flow, you can see a peaked P1 wave with a high systolic blood pressure and a dampened P1 wave with a blood pressure that is inadequate. Your P2 wave is your tidal wave. That is the wave you want to be watching closely because it shows us how compliant the cranium is or how much space we have in that box. It is said to represent the stretch of the parenchymal tissue. You want to make sure that it stays below the level of the peak of P1. And P3 is your dicrotic wave and indicates the reflective pressure when the aortic valve closes. Its amplitude is dependent on the volume of CSF circulating. Your ICP waveform is directly related to your cardiac cycle and your respiratory cycle. The relation to your cardiac cycle is fairly obvious. Remember that your P1 is created by the big push of arterial blood flow into your brain. There should be one ICP waveform for every heartbeat. You will usually see the peak of the P1 wave around the repolarization phase of your ECG. And because your ICP waveform is related to blood flow, it can be an early indicator of a problem with your blood pressure. A peaked P1 wave can be an indication that your systolic blood pressure is too high. And a dampened P1 wave can be an early sign that your blood pressure is too low. Now I know what you're thinking. If I'm looking at a P1 wave that is below a P2 and P3 wave, how do I know if it is because the blood pressure is too low or there is a loss of compliance? That takes a little bit of weeding things out. You can quickly evaluate your ICP value as well as your systolic blood pressure. You want to consider your cerebral perfusion pressure, or CPP, as well. CPP is one of the tools we use to evaluate blood flow to the brain. It's the MAP, or the mean arterial pressure, minus the ICP, and typically you want this number to be between 60 and 70 millimeters of mercury. Relation to the respiratory system is perhaps not as obvious. In the image above, you can see the individual ICP wave and a larger respiratory wave that is consistent with our respiratory pulse. Why does this happen? It happens because our respiration has an effect on our cardiovascular system. As we breathe in and out, we are changing the thoracic pressure in our chest. When we breathe in, our diaphragm contracts and our chest expands and our intrathoracic pressure drops, allowing for an increase in venous return. This increase in venous return actually causes a drop in cardiac output, which then causes an increase in the heart rate. If we were looking at an ECG or listening with our stethoscope, it would be what we term a sinus arrhythmia. These changes in thoracic pressure can directly affect your ICP value as well. 80% of the blood in our cranium is venous, and we depend on this venous drainage to maintain a normal ICP. When a patient is apneic, they're decreasing venous drainage and they can have a spike in ICP value while they're having an apneic episode. Now let's move on to Lumberg ICP waves. It is important to note that we are not talking about individual waveforms, but instead talking about cycling of ICP elevations. I want you to think of Lumberg not as individual waves, but instead as ICP trends. These ABC trends have different physiological causes, and in the case of these trends, A's are bad and C's are okay. We'll start with the bad and move into the good. Lundberg A waves, or trend, is a cycle of plateaued increases in ICP. If you were watching this happen at the bedside, what you would see is an increase in ICP that would sustain for somewhere around 5 to 10 minutes and then relent back to where it started. And minutes later, it would elevate again sustain the elevation for a matter of minutes, and then go back to where the ICP started. They are also sometimes referred to as plateau waves, because the trend, when put together, creates these plateaus like the ones pictured in this slide. Why do Lundberg A waves happen, and what makes them bad? Lundberg A waves represent a disruption in cerebral blood flow. It happens in 4 phases. In the first phase, or drift phase, the blood flow to the brain drops, which causes all the blood vessels to dilate in an attempt to get more blood into the brain. Because blood is now taking up more space inside the brain, and remembering what we learned in the Monroe-Kelly, that increase in blood flow causes the ICP to go up. Now, because the ICP is elevated, our CPP drops. Remember, CPP is MAP minus ICP. When our CPP drops, our brain cries out for oxygen and triggers the Cushing's response. When the Cushing's response restores the CPP, the ICP then drops back down to what it was before these events happened. The problem is that minutes later, the CPP drops again, and the whole cycle repeats itself. Lundberg B waves represent a shorter cycling of ICP. At the bedside, you'll see a small increase in ICP that will remain elevated just a couple of minutes and then go back down to the baseline ICP. And this cycle will happen faster than your A waves. B waves can be a normal response to respirations or variations in cerebral blood flow. We can see these B waves in vented patients and patients with sleep apnea. It is important to note that these waves can eventually progress into A waves. When this happens, you will see a more profound elevation that will last for a longer period of time. And finally, C waves represent a normal variation of ICP. This is why your ICP is labile, meaning that very rarely does a patient's ICP remain static. It will be up and down with very small, quick variations of just a couple millimeters of mercury. So when we talk about Lundberg, A waves are bad, B waves can turn into bad A waves, and C waves are normal. I hope that this has provided a deeper dive into ICP waveform analysis, and perhaps even enhanced your understanding of the physiology behind our waveforms and trends in ICP. These are important tools to help in the prevention of secondary injury and improvement in patient outcome. Here is a list of my references. Thank you for joining this presentation. If you have questions or comments, please feel free to reach out to me at kenna.seal@natus.com.